Hello, everyone. My name is Mike Palladino. I lead the clinical solutions at OptimizeRx. And today I want to talk about shared decision making and how, as pharmaceutical professionals, we can assist with this in educating both clinicians and patients. I have a very brief skeleton agenda today. First, I will talk about what shared decision making is. And then I'll show a live example and a case study of how, as marketers and professionals in this space, we can use technology to improve shared decision making. Some disclaimers here. I'm not being paid for this presentation. Much of this is my own opinion and from my own experience. I spent 9 years in clinical practice as a pharmacist at large health systems in Philadelphia. I then went to the pharmaceutical industry for 7+ years in medical affairs roles. And I've been at OptimizeRx for a little over 2 years now, really understanding patient and HCP journeys and educating those folks via one of our channels, or we're working with clients or agencies and educating in that manner. So this presentation is educational in purpose and is not me selling any particular OptimizeRx product. So what is shared decision making? It's a very simple term. It is exactly how it sounds. The AHRQ, the Agency for Health and Research Quality, really coined this term some 20 years ago. That agency has been around for 30 years. That agency was developed to really improve the safety in the way medicine is practiced in the United States. And if you go to their website, you will see a number of amazing tools and resources and research based on a number of things. But shared decision making is a strong part of really how they educate and the research that they do there. And what shared decision making is really this collaborative conversation between clinician and patient, or consumer, or the family member, to make sure that the right type of therapy, or maybe no therapy at all, is a really strong conversation piece. And when that occurs, we know that patients are more satisfied. When patients are more satisfied, we see better clinical outcomes. And that's essentially the basis of shared decision making. I urge you to go to this website to look at some of these resources and tools. I used them when I was in practice. A lot of health systems still use them to this day. A real simple example of shared decision making, before I get into a more complicated one, is I'm a parent. I have an 8 and 11-year-old. This resonates with a lot of folks in the crowd. My children used to get a lot of earaches as younger children, sometimes strep throat, and we've all had the experiences of Augmentin, or a really nasty tasting suspension given to your children, right? They don't feel good. They have a fever. Now you're giving them this medicine. They're spitting it across the room. Everybody's upset. Bad experience. The patient is not getting better. So now when my youngest child has strep or an ear infection and requires an antibiotic, and the pediatrician recommends an antibiotic, as a consumer, as an educated consumer, I can say, hey, listen, she will not take this Augmentin. She will spit it across the room. Please prescribe the bubblegum tasting amoxicillin, right? We leave, we're happy. My daughter's on the right medicine. She's on a medicine that tastes good. She takes the medicine and everyone is happy and she feels better, right? Which is the most important thing. So I think really simple stories like that, of having some level of knowledge and having that conversation with the clinician, is a great example of what shared decision making is. And for those of us that are healthcare practitioners or really consumers of this environment, that's the holy grail. That's what we want. Here is an example of a checklist that I developed, and we will kind of apply this checklist to the case study that I'm going to show you today, and is really using data and technology to define the journey of both patient and HCP. This data could be claims, it could be labs, it could be historical medication, right? And then we're deploying technology to find the right time and the right type of message to educate these particular audiences. So this is a nice cheat sheet that I developed, and we'll kind of walk through it with this case study. So here's our case study. This is what good looks like. This is what shared decision making should look like. And I'll kind of give you this approach, and then we will reverse engineer on how we use data and technology to get to this particular case study, okay? So this is a diabetic management. This gentleman on the left is Matt. You see this very short timeline, this month timeline I have on the screen. And then we also have Dr. Smith. So what we'll do here is we'll walk through what Matt looks like. All right. Matt is 42. He has type 2 diabetes. He has hypertension, peripheral arterial disease. He's on a number of medicines, metformin for diabetes, lisinopril, silastazol for his PAD. On the side, he likes to binge watch Netflix. He's a computer engineer. Matt is obviously pretty tech savvy, so he is in front of the computer a lot. And that's Matt. Now let's meet Dr. Smith. She manages a mid-sized suburban PCP office. She has a care team. She has 2 nurse practitioners. She has 1 PA. She has several nurses working at her office. The practice has been around for quite some time. She knows the diabetes space pretty well. She's actually a speaker for a number of SGLT2 brands. So when it comes to diabetes and this type of management, she's pretty well educated. On the side, she's a DIYer, and she likes to use her social media to learn more DIY tricks of the trade. So that is just an understanding of who these folks are individually, maybe what they like to do as a consumer. And now we talk about Matt's journey. So it's roughly mid-January, and Matt has noticed some more hyperglycemic episodes, right? He's had metformin on board for quite some time. About 6 months ago, there was an increase in dose, but there was maybe 1 episode, and now they've become more frequent, right? So in mid-January, Matt has another episode. What Matt does now is he proactively reaches out to Dr. Smith's office, right? So he's not just sitting there waiting for something to happen. He is taking action in his care. Matt then goes to Dr. Smith 3 to 4 weeks later. A BMI is recorded. Matt's BMI is over 40, so he would be defined as an obese patient. His A1C is taken. His A1C is elevated. So that kind of tells us that there's been quite some time that Matt has not been controlled. All right. Matt and Dr. Smith now have an interaction. They have a conversation that, hey, what is currently available for you and what you're currently using is not working, right? Is not optimal care. So then there becomes this conversation between, hey, there's these GLP-1 injectables, okay? And then there's these SGLT2s that Dr. Smith is really used to prescribing, all right? The end of the day, Matt leaves on GLP-1 injectable, all right? And so this type of conversation, this level of conversation, and the timing in which this occurs is really important. And this is exactly how we want to see the healthcare environment play out. All right. So this is, again, kind of like the gold standard of how we want shared decision making to occur. So as professionals in pharma, right, experienced folks with either clinical background or marketing background, media, consumer background, how do we use technology and data to get to Matt and to have Matt have that conversation with Dr. Smith? All right, so how are we aligning the DTC and HCP journey? I explain this in a really simple 3-step process. In the weeds, it may not be simple, but the methodology is very simple. On the left, we see audience definition. So we want to define the patient, always starting with the patient, and we want to define the prescriber or the HCP. We then want to be able to use that definition and learn from all of our historical data that many of us in this room have access to, and build an engine to really predict when that patient is ready for care. And then the right, I guess it would be the most simple and media related concept, is once we have these audiences, we're now educating them. And we just have to decide what channel works best. All right, I mentioned Netflix for Matt. I mentioned social media for Dr. Smith. And so we're simply choosing which channels to educate these audiences in. Data becomes knowledge. Like I mentioned, we all have access to data here. This is not new, but it's just numbers if we don't understand how to use it. So when I define Matt with data, I can say, well, he has a diagnosis code, this ICD-10 code for type 2 diabetes. He had a lab order, hemoglobin A1C, right? This CPT code. I have this information. I also have medication history and fill rate, as well as the milligram strength to maybe that particular medication. So we can understand dose escalation. If we understand dose escalation and we kind of combine that with doctor visits and lab orders and diagnoses codes, we can kind of get this understanding that Matt may not be managed properly on his current therapy. We then layer in what Dr. Smith may look like from a data perspective, right? What is Dr. Smith's specialty? I mentioned she's a PCP, a family doctor. We understand that Dr. Smith prescribes a lot of SGLT2s, so we can understand the HCP's prescribing patterns. When we understand all of this data, we can then train a model to predict when somebody like Matt is eligible for care, and also understand who Matt is going to go see for care. And here are the dynamic audiences that can be produced on a weekly cadence. We see a number of images like Matt. We also see Dr. Smith, and we see some other folks that are a part of her care team, right? A lot of healthcare, particularly in primary care and family doctors, you will be seeing physician's assistants, nurse practitioners. These folks all control care. They're very important to educate above just the MD. All right. So when we do both of this perfectly, we can then understand when Matt is going to see Dr. Smith, and let's educate both Matt and Dr. Smith at the right time. On the right, you see a number of channels. Again, maybe streaming on Netflix is the place to educate Matt. So we're only educating Matt during that time frame, so that when he goes to Dr. Smith and she say is like logging into her electronic health record, we have this perfect timing to educate her as well. So that when we combine both of these, we have this very nice synergistic outcome and hopefully a nice shared decision-making conversation. So here is kind of the roadmap in which we use to find data, develop an AI model, predict dynamic audiences, then educating at the right time in the right channel. So now we talk about this time frame too. This was a tight time frame, and we want to tailor the channel appropriately. I kind of use that term Netflix a lot, and Dr. Smith using social media. We also think about what type of messaging resonates. So Matt left on an injectable GLP-1. Well, maybe Matt was concerned about giving himself injections, right? So Matt's media plan should potentially involve education on how you would sub-Q inject yourself. And it could be web-based again. So when he's on the internet all day, he's served up this information. He may also think that, oh, this is an injectable. It must be really expensive. And it potentially is. But Matt has a commercial payer, and there could be an opportunity to educate Matt on access and how he could actually get drug at a low cost. All right. So now we have Dr. Smith. How is she best educated? All right. She's a different type of consumer here, right? She's a physician, so she has an understanding of this disease state. So maybe for her, the ADA guidelines should be an opportunity of education. GLP-1s have a lot of great information in the ADA guidelines, particularly with obesity and diabetes. So maybe she needs to be brought up to date on GLP-1s in the guidelines. Similarly, she may think, oh, you know what, I've been prescribing SGLT2s forever. They're affordable, my patients can get them, and she doesn't know the formulary coverage of GLP-1s. Again, another opportunity to educate on access. So when we can align both of these education points, these conversations become really valuable, all right? Then lastly, Dr. Smith has made the diagnosis with Matt and is about to send him home on GLP-1s. She's in her electronic health record prescribing drug because that's where doctors spend all of their day. And she gets notified of a copay benefit for this drug that she can actually print out and give to Matt. So this is really a full circle here of this timeline of how we identified patient and provider, the quick time frame in which we want to educate these folks, and then the type of education that we give them. And lastly, here is our key takeaway slide. We all know shared decision-making improves patient care and satisfaction. And in this life science industry that we live in, we do have the responsibility to find the right patient, the right HCP, the right time, and the right resource and channel to improve shared decision-making. That concludes the presentation. If anybody has any questions, please email me. I would be happy to have a conversation at some later time. Thank you very much.